I'd like to begin recording. And once again, let me officially welcome everybody to today's event, Can You Predict Lethal Domestic Partner Violence? Today's event is sponsored by the National Institute of Justice and the Ash Institute's Government Innovators Network. I'd like to hand things over to our moderator, Dr. Andy Klein, who is the Senior Research Analyst at Advocates for Human Potential. Dr. Klein.
Thanks, Jim. Well, welcome everybody who signed on. You're one of several hundred who are on at the moment. 1,100 people, we are told, have signed up for this, either the now or the recording later on, from every state except Delaware, which just means that Vice President Biden is busy today, I guess, and 14 foreign countries, including Bangladesh, China, Japan, Ethiopia, South Africa, and a few others. Our panel today, we have 3 people on the panel that you'll be hearing from. I think our format we've decided on is everybody's going to give a brief presentation. Then we are going to have the lion's share of the time reserved from questions from all of you that you will be submitting through what Jim just showed you how to submit, which I will then read aloud and direct to the appropriate panel member. I'm not going to spend a lot of time introducing the panel members because each one has a slide and they have we have a bio there. But the order will be, we'll start with Jacquelyn Campbell, which is appropriate since we'll be talking about the danger assessment tool that she pioneered, followed by Marci Van De Mark from Baltimore County, not Baltimore City, who will be talking about how they apply this in the real world. And then it'll be followed by Rene Renick from the National Network to End Domestic Violence, who will be giving a sort of a national perspective on this. And I will be your moderator. And I thought I'd begin with just a little bit of personal history to sort of introduce this topic. If I get my slides here. I entered the criminal justice system in 1975. I'm an old fellow, as you can see from the picture. Back in 1975, things were much simpler when it came to domestic violence because we didn't recognize it. There was no such thing. Marital rape was not a crime in most states. We had no crime of domestic violence. What we did have when I first started, if you go to the old record cards before we had computers, you would see the standard crime in Massachusetts for an assault was called assault and battery. So the abbreviation was A and B. And then occasionally there'd be a little parentheses that would say wife. Now, there was no official crime, assault and battery and wife, but that was a tip-off that this was not a real assault and battery to be taken seriously, because after that you always saw the letters DISM after that, which meant that the case was dismissed, because you knew that case was never going to go anywhere. And that's how things were when I first began in the court system. Then in 1978, Massachusetts followed Pennsylvania's lead and became the second state to enact protective order legislation, so-called civil abuse. Because the front door of the courthouse was basically locked for victims of domestic violence, we created a back door, the civil door for victims to go into, which you know they can go to the clerk and ask for an order of protection. And it never occurred to us at the time that that's sort of oxymoronic, the idea of civil abuse. If people were civil, it wouldn't be abuse. But it wasn't recognized as criminal. But then what happened in the Massachusetts legislation, if you violated the civil abuse statute, it was then a crime. So the crime wasn't that you reassaulted your intimate partner. The crime was you disobeyed the court order when you reassaulted somebody. And so we began to criminalize domestic violence through the violation of civil abuse orders. We began to see more and more of those kind of cases coming into the courts. And we started in the late 70s, started to get a bunch of these, mostly men on probation. And we, at that time, we didn't have a very good idea of who we were dealing with, what we were dealing with. And I remember a lot of the judges used to order these men to see the court clinic because the feeling was, gee, these guys must be crazy. And so we went at the court clinic, the psychiatrist downstairs, to let us know what was going on, and also whether these people should be taken seriously, were these real criminals, were these victims in danger. And the general assumption was that the professionals could handle this. The court psychiatrists could tell us whether these people were dangerous. And that was done for many years until the beginning of the 1980s. There was a famous case out of Texas, and I have on the slide there a quote from the American Psychiatric Association that admitted outright in 1983, in a brief they filed on this death penalty case out of Texas, that the unreliability of psychiatric predictions of long-term future dangerousness is by now an established fact within the profession. Well, it may have been established within the profession, but it took a long time for most courts to realize it was an established fact, because we still would rely on so-called experts' opinion of whether somebody was dangerous or not. The interesting thing is, someplace in that decision, they talked about how two-thirds of the psychiatric predictions are simply wrong. That always struck me as slightly odd, because if that were true, that means all you have to do is the opposite of what the psychiatrist says, and you'll be right two-thirds of the time. But anyways, maybe I'm misinterpreting that. At any rate, we began to start tracking intimate partner homicides. So what's happened in the last 20, 25 years or more? This slide is from the Bureau of Justice Statistics based on FBI supplemental homicide statistics. And what you can see is there has been an overall decline in intimate partner homicides, according to the FBI. The blue line, of course, is males, and the red line is female. It hasn't been uniform by gender, and it hasn't been uniform by race, as you can see. The most alarming thing is, despite the billions of dollars of federal and state money and a lot of efforts on domestic violence and growing awareness about domestic violence and the increased police response and the criminalization of domestic violence, if you look at those statistics on homicides, what you see is the greatest advance has been made on the murder of male intimates has gone down dramatically, has been reduced by almost 80% during that period of time, many of whom in the old days were murdered by victims. Remember the case of Francine, I think it was Francine Hughes, that was played by Farrah Fawcett in The Burning Bed. So ironically, the largest decrease in homicides has been with male abusers. Female abusers, the female intimates, victims who have been murdered, the decline has not been as dramatic. In fact, if you look at the middle, it's less than the overall decline in all homicides during the same period of time. So although all homicides across the United States have decreased since 1976, male intimate homicides have decreased much more, but the homicide of female intimates has decreased much less during this period of time. So the challenge is still extremely pertinent to deal with this phenomenon of homicide and dealing with it. And so that's what our topic is about today. Our first speaker is Jackie Campbell, who's going to give us some background and material on that. So, Jackie?
Hello, everyone. I also have been doing this for a very long time from a different perspective as a nurse, being very concerned about intimate partner homicides. And then when I did my first study on domestic violence homicides, I found that the number one risk factor was prior domestic violence. So when intimate partners kill each other, and this is still true, somewhere around 2/3 to 70% of the cases, whether a man is killed or a female is killed, there's prior domestic violence against the female partner. So what I was working on is to try and figure out what we could do to identify which abused women were most at risk, and I was working with women in shelters and women in the healthcare system. And then I developed the danger assessment as a clinical tool. So as you can see in the slide, again, the number one risk factor for intimate partner homicide, whether a male or a female is killed, is prior domestic violence against the female partner. And often that domestic violence is not known to the criminal justice system. Arrests for domestic violence are only 10 to 15% of the actual domestic violence. And as I mentioned, my first homicide study was in Dayton, Ohio, which was where I started developing the danger assessment, and the website for the danger assessment is there. One of the things I realized as I was talking to abused women that they were incredibly smart, resourceful, that they really wanted the violence to end, and they were willing to do many different things to try and make that happen. However, they often underestimated the amount of danger that they were in, and that's something that we have supported in further research, is that women seldom overestimate their danger, but they do underestimate their danger. So I developed the danger assessment in 1985 as a clinical instrument. It's available on that website. It's free. Anybody can download it. And the first part is a calendar to help the woman recall the pattern of abuse and have her come to her own conclusions in terms of whether or not it is increasing or not. Then as we were working with the instrument with abused women, a master's student, Elaine Stewart, one of the items that she added that has become very important is the choking item. And as advocates, as criminal justice professionals, as people working in the field, we should think of that as attempted strangulation. But if you ask a woman, she will use the terminology choking, and the danger assessment is in terminology meant to help women relate to the items. The danger assessment is intended as a lethality risk assessment versus an assessment for risk of reassault. The SIERRA, the DVSIR are very good instruments, but they are primarily intended to identify risk of reassault, while the danger assessment is intended to identify risk of homicide. This next slide shows that those risk factors for reassault, although overlapping with lethality risk factors, are not exactly the same. They're not weighted exactly the same. And the other thing we are concerned about is also safety assessment. What do individual women do that keep themselves safe? And what I oftentimes say is the cornerstone of our domestic violence advocacy is safety planning, but we really haven't tested very much which of the safety behaviors that we advise women to do are really going to keep them safer, and in which context is that going to happen. So it's not only an individual safety assessment in terms of an individual woman's safety behaviors, but also the community context. What does the community do that keeps women safer? There have been a few independent predictive validity studies that have supported the danger assessment in terms of how well it predicted risk of reassault, and that's important in our risk assessment instruments, that we have independent evaluations, not just evaluations by the person who is who has developed the instrument. The major support that we have for the danger assessment is the femicide risk study, which was published in the American Journal of Public Health in 2003. It was funded by combination funds from NIH, CDC, and NIJ. And what we were trying to do is to identify and establish the risk factors for intimate partner femicide, intimate partner homicide of women, over and above this prior domestic violence, which we knew was the number one risk factor. We found in that study, as I mentioned, that about half of the women did not accurately perceive their risk. We used a case control design We started with police records of actual or attempted homicides. The actual homicides, we interviewed a proxy informant, someone that the victim had confided in, and we compared those cases of actual or attempted femicides with women in the same communities who were abused. Those were our controls. We then revised the danger assessment based on these findings. We added a few items, reworded 2, and developed a weighted scoring with cutoff ranges. And we now have the cutoff ranges that the acronym is VISE. It's important to notice that the lowest score is not called low danger or no danger. It's called variable danger because the danger in abusive relationships of it escalating to homicide can change. Factors like the victim leaving the abuser can make the score go up. This is an ROC curve, received our operator characteristics curve analysis of the danger assessment. As I said, we developed the weighted scoring with the actual femicides, tested it on the attempted femicides, and that was recently published in the Journal of Interpersonal Violence. We also looked at the predictive accuracy in homicide-suicide cases and found the danger assessment to also accurately predict those. We did some further testing with funding from the National Institute of Justice, the RAVE study. Chris O'Sullivan and Jan Rule were my co-PIs with this. We looked at, we enrolled women who were abused in both California, the Los Angeles area, and New York City. And then we gave them 4 different risk assessment instruments, plus we asked them their perception of the probability of their partner reassaulting them or severely reassaulting them. And you can see there that even for reassault, the danger assessment, although the ROC curve is not as strong, was the most predictive. All of those instruments were better than chance. The DVSI, I must mention at this point, has been revised. It's now called the DVSI-R, and Kirk Williams has some stronger ROC curves than this. But all of the instruments did better than chance. The victim perception also was better than chance, but these were not without some significant error in terms of predicting reassault. The DV mosaic was most accurate for threats and for stalking. We're now working with the danger assessment in several new projects. In Canada, the Alberta Council of Women's Shelters, all of the shelters in the province of Alberta are using the danger assessment with all women as they come into the shelter. We have quite a bit of very interesting qualitative data from that study. Nancy Glass has been doing some testing with same-sex couples, and that was recently published in the American Journal of Public Health. She's also working now on a computerization of the danger assessment with a decision aid process. Dana Webster at Hopkins is also working on helping women visualize the results of the danger assessment so it's more meaningful to them. We're also testing the lethality assessment project that you're going to hear a bit about more in Oklahoma that's funded by the National Institutes of Justice, and Jill Messing is working with me and several other investigators on that. And one of the things that's important on that study is we have a significant proportion of American Indian women from Oklahoma in that project. There's also been a shortened version of the danger assessment. It's being published this month in Academic Emergency Medicine, primarily meant for emergency department use. And as I mentioned, the lethality assessment project that you're going to hear a bit more about. And the next slide is some references that you may want to use related to the danger assessment. I'll pass the baton.
Before you do, Jackie, there's one question that came up specifically What is the ROC curve, somebody asked?
All right. What that stands for is Receiver Operator Characteristic Curve. What that is it's a statistic that's used to determine the accuracy of any kind of risk assessment instrument, whether you're trying to predict risk of reassault and domestic violence, or reassault in terms of sexual assault, or recidivism in terms of mental health kinds of things. It's a statistic that's used for that kind of an instrument. And what you're trying to do is capture the largest percentage of cases under that curve. It's a combination of sensitivity, how well the instrument does in capturing the cases that are at high risk and indeed violence occurs, balanced with the percentage of cases where it was low risk and you were able to identify that, and that's called specificity. But it's just one percentage, and the higher the percentage is the better. And in some fields, they're saying, unless it's 90%, accurately capturing cases, that it's not sufficient. In the domestic violence field, sort of like Andy, you said in that original slide, we're not quite that predictive yet. And we're glad when our risk of reassault ROC curves are in the 70% range.
One more question before we move on. You stated that the criminal justice system is usually unaware of the DV in a relationship until the homicide occurs. Is this true for women who kill in self-defense? I'm wondering if women who kill in self-defense have tried to get legal help, perhaps on several occasions, but the help she got was ineffective. Thus, the end result of the was self-defense killing.
There's not a simple answer to that. In our study, 83% of the cases were known somewhere in the system. Now, when I said, that the arrest is only the tip of the iceberg in terms of domestic violence, but that doesn't mean that those cases are not in the system somewhere. And in our study, for instance, a lot of the cases, over half the cases where there was prior domestic violence actually had been seen in the criminal justice system. There just wasn't necessarily arrest. There might have been a protective order. The police might have been called, but there wasn't an arrest. If there was an arrest, there was a diversion, so it didn't appear in the record. So definitely in terms of actual arrests, we have an undercount of the number of prior domestic violence cases before a homicide. But that doesn't mean that women are not known somewhere in the system, either in the healthcare system, in the mental health care system, or the perpetrators have been, there's been an order of protection, for instance, out against them. So as I said, somewhere around 83% of our cases when there was a homicide or an attempted homicide actually were known to the system. Now, we only looked at men killing female partners. We did not look at women killing male partners. And there has not really been a comparable study to ours that has looked at it the other way. We wanted to do so, but we did not get enough funds to do so. So I'm hoping that, looking at women killing men, we'll have some sort of a comparable study somewhere along the line.
Great. Jackie, thank you very much. The last question was on certification for using the instrument, but I think I've seen a slide that will be coming up soon about that. So we're going to move on to Marci Van De Mark, who's going to tell us about, I think, the largest, or is it the first application of lethality assessment in the real world. Marci?
Well, I'm certainly going to discuss the real application, but in Maryland, we were not the first jurisdiction to utilize this tool. A little bit about myself. Unlike my esteemed colleagues, I come to the domestic violence arena a little bit later in life. My experience has been in systems, identifying gaps in services, and then developing programs and services to respond to those gaps. And that's how I've come to the lethality assessment program. My goal, or the goal of this county, was to take the research that was conducted by Dr. Campbell, along with the extensive work of the Maryland Network Against Domestic Violence, in developing a lethality assessment tool and bring that tool and program to Baltimore County. So with that introduction, let me just tell you a little bit about Baltimore County. We are not the city. And as you can, Jim, can you pull up these slides? No? And as you can see from the first slide, Baltimore County is a large jurisdiction. We're actually 682 square miles around. We surround the city, and in doing so, we actually share in many of the same problems that the city experiences, but we're not the city. We are a large, Jim, I'm going to need you to push these slides. My computer isn't working.
Sure, no problem.
Go to the next one. We're a large jurisdiction. There's 24 jurisdictions in Maryland. There's 28 counties and one city, which is Baltimore City. We have a population of about 800,000. We have a median income of about $52,000, and we're the third wealthiest in the state. We have less than 10% of our folks are in poverty, and we have a very high concentration of seniors. As you can see, almost 15% of our population is 65 or older, with also a large concentration of young folks between the ages of 0 and 17. We are a predominantly white jurisdiction. We have 25% of our population is African American, with 4% that are Asian and about 3% that are Latino. So what I'm going to describe for you is the process we went through, this jurisdiction went through, in determining whether or not the lethality assessment program was an appropriate approach for us to use. And what I will very briefly describe is first 5 steps. So any jurisdiction could use this, or any community could use this to first determine if the lethality assessment program is appropriate. And then the second piece of this, my presentation, will focus on the actual steps in implementing the lethality assessment program. So according to the next slide, the first step is defining the problem. It's an assessment, and it's incredibly important, I think, for any community when they look at domestic violence to first come to terms with the fact that domestic violence in any community is a community responsibility. It requires a collective response. So in defining the problem, we looked at our police statistics, and the first thing that you can see is that from 2006 right up until now, there's been a pretty consistent number of police calls for service. The numbers you're seeing in 2006, 7, and 8, that references services for domestic violence calls for service. Overall, in Baltimore County, annually there might be 600,000 calls, so you can see that this is a percentage. So the first thing was recognizing that we had a lot of calls for service, and we had many repeat calls. The second, as this next slide indicates, we had a consistent number of fatalities in our community, and as a community we simply decided that one fatality was one fatality too many. So consistent with the national trends, there was not a spiking up. There was kind of a downward climb until this year. In 2009, and this is fiscal year, you can see that we had a significant increase in the number of domestic violence fatalities. So part of defining the problem was that we have a large number of calls for service. We had a consistent rate of domestic violence homicides. There was a generalized concern that the response to domestic violence was not consistent among service providers, among the police department, among even from within our own department. And there was another concern that when police officers did respond to a domestic violence scene, that there weren't the resources available to them on the spot. So that was a problem for us. And the next step was, in doing your assessment, is looking at who are the partners that provide the service. You need to identify all the players. The next step is to look at identifying in your community what is, meaning what are the resources that are actually in place. And Jim, if you go to the next slide, you can see in Baltimore County, we have the luxury of having pre-treatment agencies. And the reason for that is we are a geographically large division with very distinct communities. So in our jurisdiction, you have the east side, you have the west side, and then you have central Baltimore County. And we have one service provider in each of those jurisdictions that provide services to folks who reside within their catchment areas. In addition, we have a Latino program that helps to serve throughout the county, the Latino population. So when we look at existing resources, you'll see that we were reasonably rich in services. We had a hospital-based program, which was Northwest Hospital. And within our own police department, we had domestic violence coordinators. There was one coordinator in each of the 10 precincts. The Department of Social Services provided direct services for victims, for coordinating services for offenders, and the domestic violence 24-hour hotline. We had an emergency room companion program for women who had been sexually assaulted, and the last two services are actually have oversight functions. The Criminal Justice Coordinating Council is a local council that oversees all the activities that relate to reducing criminal activity in the community. And the Maryland Network Against Domestic Violence is a state coordinating agency of which every jurisdiction is represented in they have a coalition of sorts. And that is the organization that works very closely with Dr. Campbell in developing a lethality assessment tool. So once you've gone that second step, identifying what is in place, the next step is an obvious. You identify what needs to be. And as the next slide shows, Jim, we knew that we had some work to do in developing resources. While we had a number of service providers and resources in place, what was lacking was coordinated leadership, bringing those organizations together, helping them work together. We needed to identify collaborative opportunities. There was a definite need to strengthen communication and cooperation between the public sector, police department, the Department of Social Services, and the private sector, the service providers. And when we brought those folks together, what came out of that effort was a coordinated effort to examine strategies to reduce the incidence of domestic violence. And at that point, keeping in mind that on a state level, the Maryland Network Against Domestic Violence had a designated individual, Dave Sargent, who's an expert in this area of lethality assessment, who was working with each jurisdiction to help guide them in developing a lethality assessment program. And he was an integral part of he was a wonderful resource, providing the information, the skills, and the expertise to help us continue our momentum to move forward to look at this lethality assessment program. And our looking at this tool brought us to the point of deciding that as a community it made sense to select this as an approach to reduce the incidence of domestic violence and domestic violence fatalities, and to help us create a more coordinated and response to the whole incident. So what does the lethality assessment do? As the next slide indicates, it was a tool developed, as I just said, through the network and Dr. Campbell's research. It trains police officers or first responders, because it's expanded greatly, its usage has expanded greatly, to use a series of 11 pointed questions to identify abuse victims most at risk of being killed. It's completed at the scene by the responding officer. And if a victim screens high danger, the victim is immediately connected on a lethality response line. It's a designated line staffed by professionals who guide the victim to either do safety planning, access services, and or there's a capability of actually connecting them directly with a service provider. And that brings us to the point of we decided this was a good tool, and the next step was, does this county move forward in implementing it? Remembering that we're a large jurisdiction with many partners, that took a bit of work. And what ended up happening is, as the next step, there was an agreement that we would pilot this program in one precinct, and a precinct was selected based upon its high concentration of domestic violence. And there was an agreement among both the police department, the service providers, and this agency that in piloting this project, we would establish a single lethality response line that every officer could contact. The service providers brought to the table that they would shelter anyone who requested shelter, and that was a new resource for the police officers. And the police officers in return agreed to connect on this lethality response line victims with an immediate resource. So the first step, and this is a 6-step process, so the first step in trying to get this program implemented was we needed to promote the concept, and that meant reaching decision makers, the key people who could actually make this program happen. The next thing was we had the partners, we needed to bring the partners together, and we needed to strengthen our relationship in a way that we started to coordinate and cooperate and not operate independently. And then the third piece was we actually implemented this pilot, which included the steps that I just described. And what came out of the pilot, and this is really a key piece to our whole process, when you implement a pilot, you have to decide up front what data you're going to collect. And for us, we learned a lot from our pilot, and key to all of this is it was an educational process. We learned that 56% of the folks screened in high danger. I think all of us were surprised to see that high of a number actually being in a situation where they were at risk of a fatality. The process, we were able to streamline our process of getting the victim from the incident, to the police, to the service provider. And that really helped to do two things. One is it empowered police officers to feel like when they left the scene, they had actually helped a victim. And secondly, it resulted in increased numbers of victims accessing service. So some of the data we collected, what did we learn from this 12-month pilot? We learned that, one, there was a reduced number of repeat calls for service. We learned that there was an increased number of calls for service, and we truly believe that that was an indicator of a higher or an improved quality of interaction between the police officer and the victims, as well as there was a clear responsibility on the part of the service providers to provide a service. They did home visits within a 8-hour period of time. So we believe that the advocates supporting victims with resources increased their willingness to call for assistance. We saw an increase in the number of violation of protective orders, and of course we believe that in connecting victims with service, we know that we've reduced their risk for severe assault and by 60%, and that we've increased the number of people who are in service, which again decreases their, hopefully decreases the possibility of severe assault. The fourth step was to disperse, not only the collection, but then the disbursement of the information, the data we collected from the pilot. And in this process, we were doing many things, one of which is we had our first annual domestic violence report, which was a report to the community on the extent of domestic violence. So we used that as a tool to disperse information. We had set up newsletters. We set up regular meetings. We became part of a structure that communicated information to key decision makers. That's the Criminal Justice Coordinating Council. The fifth step is it's imperative that training be extensive, that it be thorough, consistent. Consistency is key, and that it be repetitive. And we did a lot of training to ensure that folks were trained when we got ready to expand this pilot. And of course, the data we collected supported the expansion of the program, and that's what we were able to do this year in May of 2009. Expand the program from one precinct through the 10. We're still in the implementation process, and we're still learning.
Great. So in your pilot program, when you said 56%, Marci, turned out to be high danger, were these mostly incidents that had been called into police on 911?
Every one of these were 911 calls, yes.
And what kind of volume are we talking about?
Well, we're talking about one precinct. So we actually there were 295 victims. And, Jim, I've got that statistic, that slide if you want to pull it up. We had 295 total victims who were screened. And of that, 165 high danger. And no, it's not the calls for service. It's in the pocket slides. And 100.
Okay, I'll find that and call it up real quick.
Okay. And as the chart will indicate, 141 of those 165 spoke to the lethality response line. And I think the number we're most satisfied with is that 52 of those folks actually called a treatment agency. So we were able to forge that initial connection with an agency, and our experience tells us if you can go that first step, next time it'll be easier to do and hopefully act.
Great, Marci, thank you. Before we move on, one specific question. How do you finance shelter for all these individuals?
Well, this is the interesting piece of sheltering. That was of grave concern to us in our early discussion of how do we assure that there's shelter space for everyone. And we collaboratively identified a pot of funding to ensure that there would be sheltering space available. However, the fact is very few women actually request shelter. They either remain in the situation with the partner leaving, they go to a friend's house, they go to family's house. So the sheltering costs ended up being much less than anyone expected. And that was indicated that's also indicative of statewide statistics.
Two quick questions. Your fatality rates were increased in the last fiscal year. What about in the precinct where you piloted this program?
Well, that's interesting. We didn't have any fatalities in that precinct.
Okay. And you have the before and after?
I'm so sorry, I couldn't understand you.
No, you didn't have any. Did you have any the year before in that precinct?
Yes, we did. Yes,
okay.
we did. I don't have the number right in front of me, but I can certainly get that for you.
All right. Well, we'll hold the rest of the questions until we get to the end.
And if I could interrupt for a second, Marci, I just wanted to make sure I called up that table, even if we can only show it briefly. Were either of these the table you were referring to?
Right one. Whoops. That's correct. Thank you.
This one? Okay, great. I'm going to leave that up for a little bit as we transition to the next presenter.
And if I could say just one thing briefly, in terms of the 56% of the women being at high risk using the lethality assessment screen, first of all, it is true that women who call the police are going to be more severely battered than other women, other abused women in the community, so you're liable to see an increased risk. But we also calibrated this brief lethality assessment screen to be more sensitive, and you know, it's okay with us if it overestimates risk. We wanted to be sure and capture everyone that was at high risk, and didn't worry so much about the false positive or sort of false alarms in this particular application of the danger assessment.
Okay, great, thank you. Rene Renick, do you want to let us know on the national view here?
Fantastic, thank you. And I'm sorry, you're going to have to give me a hint on advancing the slides. Did I find it?
Sure. I can do it.
Just a little bit slower. Okay, I got it now. I'm going to start this section in talking about the implications for practice, and then I'm going to move on to a little bit about policy. But if I could sum this whole section up in just one word, it would be, I think, what you've already heard before, and that collaboration is absolutely key. And okay, there we go. And I think the first place that I see a really important example of collaboration is in this research. And that researchers and advocates need to be working together. This is where we get the most powerful work. And many, many kudos to Dr. Campbell and also to NIJ, who really have shown a commitment to working with the advocacy community, and making sure that it's informed by advocates, and that also then that research gets back out to what's happening in the field, because this is important information that needs to get out. And there's been times when we haven't always had, there's been a little bit of a gap between what's happening in research and what's happening in the field, and it's so important that they work together. I also think this is just really important to recognize the Maryland Network against Domestic Violence for the creation of this project. It could not have been created or implemented without this incredible kind of collaboration. Okay, I'm searching for the slide again. Okay. My wish would be that this project would be implemented in every community across America. I think it's just so important. What we know right now is that there are 3 women die in the United States every day as a result of intimate partner violence. And we now know, because of this incredible tool, that we can predict it and we can prevent it. And the first thing I would say about this is really a community issue. As you heard Marci talking about putting together all the partners, I think it's really critical that the entire community be a piece of this. And that's where I go to, I think one of the first steps in terms of implementation is getting together that coordinated community response, getting everyone at the table. One of the things that obviously you heard Marci talk about is that when you implement this kind of program, what happens is your hotline calls go up, your calls for shelter, although they're not happening in Baltimore County, are going up in many other places where this is being implemented across the country. And what that means is that there's going to be increased demand. So the community needs to sit down in that response and say, okay, what are we going to do when all the shelter beds are full and we have another high danger case that needs to come into the shelter? And the solution to that problem is probably going to be different in every community, but that's where everybody needs to be at the table to talk about what are we going to do when that happens, because we know this is a high danger case and we have to protect this woman. Other partners that need to be at the table are people like school administrators. So we have this woman in the shelter, but how are we going to make sure that he can't find her at the school, or the school doesn't let him in? So it really requires that everyone come together to make sure that we wrap around these women and offer them both services and protection. Obviously, the next piece, and again you heard in Marci's presentation, was so important for domestic violence programs and law enforcement to be working very, very closely together. And not just once a month, but probably in the startup, and maybe Marci can speak to this later, but important that they be talking to each other maybe even daily and talking about how is this working, learning together, refining things, making this a really close partnership.
Hi, Rene. This is Jim Cooney. Sorry to interrupt you, but would you mind just either speaking a little bit louder or perhaps getting closer to your phone's
sure.
microphone?
Okay, sorry. Is that better?
That sounds great, yes.
Okay, thank you. For example, one of the things that happens is when the police go out, they do the screen, they find that there is high danger, and in fact there's a gun in the home. Are they removing the guns? So it's important to talk through those things. The law allows for that, but it really it varies across different police departments and jurisdictions. So it's important that all the parties sit down together and work out some of those things in the beginning. The other thing I really see from this is a asking law enforcement to change its practice, and it's also asking domestic violence programs to change their practice as well. And so that's a really critical piece, that everybody take a look at that. I think the mantra for using this program is safety first. A couple of things that are really critical is domestic violence programs must have a 24-hour hotline. That's critical that the police be able to get this woman on the phone as quickly as possible. Programs need to be thinking about, if we have increased demand, we have increased hotline calls, how are we going to meet that demand? Do we have the staffing in place to do that? And then the next piece is we need to be looking at all of our procedures and our rules and saying, are there any barriers in our procedures, in our rules, that could keep a woman from getting services? For example, in some shelters, they may have rules that we're not going to accept a woman into shelter if she's been drinking, or if she has been here before and we didn't think she was a good fit. Again, we need to remove those rules. This is about safety first and getting that woman into service. So really important that programs look at those procedures and make sure they remove those barriers. I think the next piece that's really important here is oftentimes what's happening with the use of this assessment is women are coming into services or shelter sooner than they would have before, or we're reaching women coming into services who maybe would have never come to service. So I think it's also important that programs really look at the services they're offering, their programming, because they may be working with a very new population. And so it's going to be very important to keep talking to those women, finding out what they need, and making sure that they alter their service accordingly. And I guess the two last things I would say about that is the importance of immediacy. Programs need to be set up to make sure that they can offer immediate services to these women. Next week is not soon enough. It needs to be absolutely immediately. And again, as you heard with Marci, follow-up is really key to ensure safety. Okay. Some other things that programs need to be thinking about as they're implementing this kind of programming is to make sure that shelters and buildings are secure. Security systems are in place to not only provide for the safety of the woman, but also for the employees, and to have a crisis plan in place. This is really critical. There's a high potential that you could have a batterer discover a woman at your location, at the shelter, at the non-residential service. And so what are you going to do? It's important to have those plans prepared for and in place, and make sure that all the staff knows what those plans are. The next piece is to make sure that the staff is taken care of. What we're finding in places where this program is being implemented across the country is that as more high danger cases are coming in, so does the staff level increase, the staff stress level. So it's really important for administrators to recognize that probably the stress level is going to go up, and it's important for them to recognize what those signs are and respond to those staff needs. Important to provide information on vicarious trauma, and look at how can you implement programming that's going to really support your employees, such as making sure you have an EAP program, a wellness program, and that you're listening to those frontline employees and making changes as they recommend. So you continuously learn and refine your programming so you best meet the needs of the women who are seeking your services. And finally, if I sum up the first part about practice in the one word of collaboration, I think in terms of policy, the one word summation here is funding. Funding is so critical to be able to provide the safety for these women, and to do this kind of screening, to do this collaborative work. So a couple of federal pieces of legislation that I wanted to point out to everyone is first is the Family Violence Prevention and Services Act, also known as FVPSA. This is really the bread and butter funding for domestic violence services across the country. It is long overdue in being reauthorized, so I encourage you to pay attention to this bill and make sure that you follow the action alerts on this and call Congress and make sure that this bill passes and that it's fully funded. And then the second piece is the Violence Against Women Act. This was originally enacted in 2005. This has been a huge piece of legislation that's provided funding for these kinds of collaborations. Again, a really important piece that we'll be seeing coming up for reauthorization very soon. Just to end real quickly, a couple of resources. I would hope people interested in using this really important tool and implementing this program would contact the Maryland Network Against Domestic Violence. They really are the experts on this and have a great deal of history and wisdom about it. And then lastly, I would ask everyone to go to the National Network to End Domestic Violence website, log on to our public policy, and sign up for our action alerts. We hope that FVPSA will be reintroduced in the House next week. The action alerts will come out, and we really need your help to make those calls. And by doing that, we all have a part of saving lives.
Great. Thank you, Rene. Before we go to questions, just two quick housekeeping matters. There are going to be, as you can see right now on the screen, a series of polls for you to fill out. When you see a poll on the screen, just click to record your vote. So it will give us some feedback and some information that may be of interest to everybody, including ourselves. Also, if you have a question, please fill out the question, click on the question Q&A and put your question in, and we'll try to get to all the questions. Somebody asked whether these slides would be available after the presentation if somebody wants to download them. Is that, Jim, will they be available?
Yes, they will, pending each presenter's permission, which I'll work out with you guys over email.
Okay. And then they'll get them in the same website?
Exactly, yeah. They'll go up at the same time as the recording, and if they're all registered, well, everybody who's logged in, I have your email addresses, so I will notify them when they go up.
Okay. All right. Let's go to questions. Let me use my prerogative as moderator to ask a question, Marci. One of the concerns that some people have with lethality assessments is that it will be used to focus attention on potentially lethal cases or high-risk cases, but it will diminish resources to non-lethal cases of abuse. What was your experience, or what's your experience been so far in the county?
I'm trying to figure out how to best answer that. It's actually increased service provision to domestic violence victims overall. And by that I mean in this jurisdiction, we made a decision to conduct home visits with the domestic violence coordinator, that's the police, along with an advocate to every victim who screened in high danger. Prior to the implementation of this program, there was not a consistency in conducting home visits. So overall, more victims are being seen. And secondly, we've ensured that there's shelter space for any victim who screens high danger. Prior to the implementation of the program, there was not that guarantee. It was on a first-come, first-served basis. So I think that we've increased services overall to anyone who participates in this tool.
And if I could come in on that, when we look at the jurisdictions overall in terms of all the different jurisdictions that are using the lethality assessment protocol, and I believe that this is on the Maryland Network Against Domestic Violence website. I don't have it. Unfortunately, I don't have it in the pocket slides. I'm sorry. But we do definitely see a significant increase in women going for some sort of services. Now, they may not actually go into a shelter, but they go for some sort of domestic violence services. Overall, and this was through 2008, and this was 63 different agencies, and they would be individual police departments, and all of these were set up in collaboration with their local domestic violence advocates. That 5,600 of the women, 57%, screened in as high risk. Actually, half of those, or 3,118, actually talked with the domestic violence advocate at the scene at the time of the police being there. And, of course, we feel like that's incredibly important because one of the things that the first responders said was that they oftentimes thought it would be a high-risk case and would give the referral number, but they were afraid that the woman would never follow up on making that phone call. So more than half of the women that screened in as high risk actually talked themselves to the advocate that at the time of the incident. And then about a quarter of those, or 854, actually went for services. So, and I think that the advocates overall and the first responders feel like overall that 854 women are 854 women at high risk that otherwise may not have ever actually gone to any domestic violence services. So, and that's what this was set up to do. I mean, the danger assessment itself is oftentimes used in the shelter to help individual women see their own risk. But this kind of lethality assessment, the whole purpose is to get women in that, especially the women that are at high risk, to make an actual contact with domestic violence services, because we know that that's how they can be kept the safest.
So based on those figures, are you saying about a third to a half are told they're high risk, but they do not follow through, or they still don't go to the services?
All right. So 57% are told they're at high risk. About then 44% of those do not actually speak with the advocate. And the other thing is that, that's immediately going for services. So we feel like actually talking to an advocate on the phone is sort of the first step of making personal contact, and that even though they may not have gone for services, that they actually talked to that advocate and got some safety planning over the phone, and might be more willing to call them back, another time, since they'd made that contact.
Here's another question, Jackie. Is there any training certificate for danger assessment, and if so, where can somebody go to get training?
Yes, there is, and if you go to that danger assessment, all one word, .org or .com will get you there. On the website, it tells you how to do the training for certification, and you can either do it with me in a live appearance, and it tells you all the different places I'm going to be in the future where people might be able to go, or you can do it online.
Great, thank you. Here's a question. I guess, Marci, where are the men in these high danger cases referred? That is, they don't cease being dangerous once the partner receives services. So what is being done about his behavior and his reasoning patterns?
Okay, I'll answer that, but I wanted to go back and build a little bit on what Jackie was saying.
Okay.
In terms of reaching victims, one of the benefits of the lethality assessment program is that it ensures that not only do we reach out to our high danger victims, but the police and or the advocate ensure that information is provided to every victim. So before it may not have been so consistently provided, but we actually have written materials that we hand out to guide folks into women into seeking treatment. And again, reiterating what Jackie said, it's imperative that if you can best reach somebody when they're in the thrust of a crisis. And I agree. Our experience has been that if we can connect the victim on the lethality response line, even if they may not connect with the treatment agency in the moment, we've strengthened the possibility that they will in the future. The other component to this, besides seeking services, is looking at are women following through with protective orders. And our experience has been that there's an increase in following through with the temporary orders and then the final orders, as well as anecdotally, because we don't have hard data on this, we're seeing more women testifying at these hearings than we have in the past. So we look at that also as an indicator of success. In terms of resources for the batterer or for the offender, Baltimore County offers two possibilities. For someone who is identified as a first-time offender and has not violently abused the woman, we have something called a short-term program. It's called Healthy Relationships. And for offenders who are either repeat offenders or have used extreme violence or a weapon, in the incident, we have a 26-week abuser intervention program that tries to engage the offender in changing the way they behave and the way they view women.
Marci, have arrests gone up in the precincts that have implemented lethality screening?
What we have found is that across the board, you're seeing a higher rate of arrest on the scene of the batterer. Yes, so the answer is yes.
Okay.
But basically, the way first responders are trained in using this process is they do what they're supposed to do regardless. You know, if an arrest is warranted, they make an arrest.
That's right.
They give the woman information about how to get an order of protection, no matter what the score is on the lethality assessment. So, that's a separate component of the police job. But in the pilot work that we did, the police officers found that it was easy to use and that they feel like it's really an important adjunct to their job, so they didn't find it burdensome.
Here's a question, Jackie, for you on the assessments. What about sexual assaults as part of the dynamic of the cycle of violence? Is there an attempt to assess this aspect?
Well, one of the questions on the regular danger assessment is forced sex, and we use the language forced sex because, again, just like we use the language choking, that's easier for women to respond to. And we do have that forced sex question is not on the lethality assessment protocol, just because, and we had great conversation about this with our advocates and with our police officers, that they felt like that was a very personal kind of a thing, and they will, if there's an indication of sexual assault, just like they would assess for that in any first responder call, if there's been domestic violence, they assess for sexual assault, or they find out about sexual assault. So that goes on their regular police report. But that because it's such a sensitive area, they felt like it was better to leave it for the advocates to ask in the full danger assessment.
Okay. Marci, does the Baltimore County program integrate child welfare? If so, how?
I think we did that in two ways. One is that the child welfare or child protective is a component of the Department of Social Services, as is the Family Violence Unit. So there's a lot of communication and sharing of information and training. And our staff, as are the police officers, are trained if they see an incident of a child being harmed, they'll immediately report it to Child Protective Services. So we're all very child-focused in the work we do.
Okay. Rene, maybe this you can answer this on from rural jurisdictions. What is done when an officer does an assessment and comes up with a high-danger response, and the incident takes place in a location where the victim and the officer do not have access to a telephone?
Oh, my. I think that's one of those things. I would go back to that sort of planning and implementation process, is talking about do we have all the tools to make this work? So I would, go back to that piece and just talk about how important it is for everybody to be at the table and to walk through all the things that are going to be needed and how you can best leverage the resources that you have to make sure that you can get that woman on the phone to an advocate. And again, I think that's going to look different in every community, but getting everyone there at the table to brainstorm it is going to be the best answer.
But if I can just say that, I think on a practical level, you'd have the officer transport the person to a precinct where he can access the a lethality response line or the resources that he needs. I mean, that's what we discussed as a possibility if there was no phone available. But,
one of the things that we found in a lot of the jurisdictions is that, especially where there are dedicated domestic violence police units, that they have oftentimes have a dedicated phone that's part of that responsibility. So that solves that. And in a lot of jurisdictions, the officers will go ahead and use their own phones. I think it's important enough that they're willing to do that.
And we found that phone access was a major barrier to overcome, and because there were a lot of questions initially by our police officers about what do they do, and if there is no phone or if you don't, you're discouraged from using a landline in the victim's home. So what do you do? And our experience has been just what Dr. Campbell said. People, we don't have dedicated phones. The police officers do not have dedicated phones. So they either use their personal phone. There's techniques to use a cell phone if it belongs to the victim. And when neither of those are available, they can bring the victim in the police car to a precinct to access whatever resources they need. And the phone usage or the phone access has not been a problem when we actually went into implementation, but it was a discussion prior to.
Here's an interesting question. We'll start with you, Jackie. What role have batterer intervention programs played, given their unique perspective of working with perpetrators? Have any programs been using this instrument, and what do they do with it if they do use it?
As far as I know, there have not been any programs that have used the lethality assessment project screen, and that's, that might be a possibility. However, when I think about a coordinated response, a coordinated community response around the use of both risk assessment instruments, risk of reassault, and lethality assessments, it makes sense that the batterer intervention programs would reach out to the partners of the offenders that are in the programs, or the offender intervention programs or perpetrator intervention programs. And I know usually most of the programs do at least send a letter to partners, but I'm talking about actually reaching out to them. And one of the things they could offer them is to go through the danger assessment with them over the phone, for instance, because with the notion of helping women see their own level of risk. The other thing that there's at least one risk assessment instrument, risk of reassault, that's been developed just for use in batterer intervention programs. So either using something like the DVSIR that you can get all the information you need from the police reports on a risk of reassault, or something like the Donald Dutton's instrument, which is I'm going to forget the name of it here, but I'm going to pull it up for myself, it was developed just for batterer interventions programs. It's called the PAS, and that's available in the literature. So there is quite a bit of interest in using some sort of risk of reassault in batterer intervention programs, and I think that's appropriate. But you have to think through, okay, what's the protocol going to be? I mean, just like we developed this protocol for the lethality assessment project, you have to think, what's your purpose, what's your protocol, who are you going to share the results with? If you use it in offender intervention programs, are those results going to be shared with partners, if it's a high-risk case, or is it going to be shared with the criminal justice system? So that you have to think through some of the other things besides what instrument to use where.
Okay, thank you. Rene, would passage of, and I don't know what the CEDAW, which Senator Kerry is working on for the next legislation, have an impact on funding? First of all, could you tell us what that means if you know?
Could you repeat that for me? I couldn't hear part of that.
Passage of CEDAW, apparently to be filed by Senator Kerry. They want to know whether that will have an impact on funding in programming.
CEDAW. I'm not familiar with it.
Maybe,
I know Senator Kerry is supposed to be introducing the International Violence Against Women Act, but I'm not heard of that one.
Well, maybe Julia B., you can recommit that question and spell that out so people know what it is.
I would suggest that if people want to know more about what legislation is happening right now, to go to our website and look under the public policy area. We also put out, it's called a briefing book, where we list all of the national legislation that relates to violence against women and children. So that would be a good place to find out more information about that.
Good. There are a couple questions of people who haven't seen the 11 questions. Those are available, Jackie, on the website you mentioned? The actual form?
The 11 questions of the lethality assessment project? It's not available on the danger assessment website, but I believe, I know you can get it through the Maryland Network Against Domestic Violence website. On that website, on the lower right-hand side, it says lethality assessment project.
Okay. And Marci, what's the website for them to go to?
It's exactly the one that Jackie just said, the Maryland Network Against Domestic Violence.
Okay.
You might want
to... one word?
I'm sorry? MNADV.
Okay.
Okay, and it just came up. And you might want to look, Jim, I'm not sure if I included a slide of what the 11 questions are.
I'll take a look and pop it up if I've got it.
Okay.
I wanted to get some clarity on a statistic from earlier in the presentation, Dr. Campbell, showing a slide showing female and male homicides. Can you repeat where that stat came from or how the numbers were captured?
Male and female. Well, good question. Let's see. I just knew which one that was. I'd be much smarter. The prior intimate partner violence in at least 70% of the cases comes from, first of all, that American Journal of Public Health reference in 2003, and that's Campbell et al. And then when a male is killed by a female partner, that 70% comes from the first study that I did that's Campbell 1981. That is the last one on that reference slide.
Okay. Here's a question. I'm currently working on developing a pilot DV program for utilizing GPS for our state. We are considering the danger assessment and the DVSI for assessment of victim perpetrators prior to considering GPS. I'm wondering if there is a recommended assessment for safety case stability that would be advised for use to determine safety for release from GPS monitoring, or a recommended objective assessment for safety that has been used in other similar ways to determine safety after intervention. Jackie, do you know if have they used lethality assessment in GPS programs? Or?
Yeah. Well, I think that for that kind of purpose, probably the DVSIR would make the most sense, because you don't necessarily have the victim to interview, and you really need the victim to interview to do the danger assessment. So the DVSIR has good support in terms of, and it's been used quite widely in Connecticut at various points along the adjudication process. And as far as, pre-post intervention, the problem is with all of these risk assessment instruments is there's a lot of the variables, or a lot of the risk factors are static. They're not going to change because they have to do with things about either the abusive relationship or about the perpetrator. So, as far as using them pre-post an intervention to see how well the intervention works, I'm not sure. I mean, I'd have to look carefully at some of the items and see what happens. But, what you would do is something like a DVSIR before you did the GPS monitoring, and then look to see how much reoffending there is, but you have to get that reoffending information from the victim. You can't just look at arrests.
You'd probably want to interview the victim before you would decide whether to put somebody on GPS.
Well, yeah, I don't know if you would necessarily have to interview the victim before, but if you really want a true picture of how much reassault there is as an outcome measure, then you have to interview victims.
This is a question for Rene. It's a fairly loaded question. How can DV victims get their county DV advocacy agency employees to fight for the victims' rights and not succumb to the politics of the upper management of the county?
Well, there you go.
That is a tough one. I think that, again, I don't know that I think so many pieces to this, I'm not really sure how to answer it, but I guess I would say to, start talking with the program, and it sounds like it's a county-run one, and, making that voice heard, and set up a meeting, sit down and talk. What are the issues that are coming up? What's not being addressed? I always start with that first place of, if you can set people down in a room and talk about the issues, maybe you can get to some resolve of that. That's probably not the answer this person's looking for, but without more detail, I probably can't answer that much better.
Marci, in Baltimore County, what is preventive measures being done to target the men who make the women being in high danger? Is there a specific protocol for what happens when the police or the first responder rates the case as high danger?
No, they're really, other than the provision of if somebody is arrested and they go through our judicial system, the judicial system has the responsibility and authority to refer offenders to treatment programs. So we're dependent upon that system to to follow through with the referral. And then once one of our domestic violence programs, we have in place a monitoring system so that if they fail to complete the program, they go back to court, and we're dependent upon the court system to either to further penalize the person or to resend them back to a program.
I'm sorry, go ahead.
So we're dependent upon the judicial system to do that piece.
Well, this is a follow-up question that sort of follows that question. If a high-risk abuser is arrested, is this information passed on or used in terms of making bail determinations?
It absolutely has become a part of the bail review, yes. And it has.
So whoever makes that bail decision is privy to this information?
That's correct.
Okay.
Bail, yes, that's correct.
And have you had any statistics showing that that's changed bail practices and release practices?
We don't have the data yet because that's a whole separate area to collect data on. But what we do know is anecdotally we're seeing an increase in the number of people who are having higher bail placed on them or people being incarcerated.
As a result of the lethality assessment?
Yeah, as a result of the lethality assessment tool.
Do you recommend, Jackie, law enforcement conduct a shortened version of the danger assessment or the lethality assessment on scene?
Oh, I think the lethality assessment protocol works very well. And,
Okay,
that's
the 11 item?
Yeah.
Okay.
And the way that works is the first 3 items, if any one of the first 3 she says, yes, that screens her in, so you don't even have to go any further. So, it's very, as I said, we know that the police find it easy to work, to use, so I think that just makes really good sense to use that one. And I was just looking at the Maryland Network website, and when I said there was 842 women who had the 3-year totals had sought help. We're now up to 1,042 that actually went to domestic violence services. So just in the last couple of months, and one of the things that's really good about this project is that Dave Sargent and the Maryland Network actually keep track of this data and has all of the participating agencies.
And does it have the before data? Does this represent a 50% increase, a 100% increase, or how does this compare from before the utilization of the assessments?
That we don't know.
Okay.
We don't know how many of these are unique, new, women that would have never come anyway. We don't know that for sure, but it's still 1,000 women.
This question is to Marci or Jackie. A comment on how courts, including specialized DV courts, should use the danger assessment or other lethality assessment tools during the court process, both criminal and civil. First of all, are we aware of any civil courts using the lethality assessment in custody or issuing of protective orders?
And not that I know of the lethality assessment project per se, but I do know that some judges are accepting the danger assessment as a piece of information for child custody cases.
Okay. Anybody else from the panel?
We work closely with our state's attorney's office. They also have a domestic violence unit where their staff actually work with the victim to help prepare them for the court experience, and that they absolutely are using the results of the lethality assessment tool as part of mounting their defense or their prosecutory action.
And that again, our prosecutors, we have a dedicated domestic violence prosecutor's office, and they're using their advocates are using the full danger assessment. So again, that's when you get everybody, all the players sitting down together talking about, okay, we're going to start using this in what sector of the system and how does it get, entered into court proceedings, if it is, at what point. And, that's when it's just so critical to have everybody sit down and talk to each other and figure out what's the best use of, this new evidence-based tool in our toolkit.
I have also known that, I'm sorry, stepping on your toes there, I was just going to say I've also known of the danger assessment being used in sentencing. And it's been very successful there.
I was just going to add, before I left probation, Massachusetts, we changed our standard intake form. We always ask, do you have kids? And but we added, who is who biologically are the kids? Are they the children of the batterer or stepchildren?
Yeah.
Because of the lethality. And I was just going through the notice the other day, and unfortunately I forgot to write down where, but in Chatham County they implemented lethality training, and as a result they started to take strangulation cases more seriously, and as a result they have more than doubled the aggravated assaults, which is what they charge strangulation as a result of lethality assessments.
Yeah.
Okay. How accurate is the assessment as a predictor of same-gender lethal partner violence? Do we know that yet, Jackie?
Well, as I mentioned, Nancy Glass did a smallish project on same-sex females using the danger assessment, and we do have some evidence that supports its accuracy with risk of reassault. We only had a very few same-sex couples in our femicide study. We did look at those separately. The dynamics looked the same, but we didn't have enough to really do a statistical analysis of accuracy. So we have some evidence that it works fairly well for reassault, but we're not entirely clear in terms of how accurate it is for homicide and same-sex couples.
Is there any material on mutual violent cases where both parties are intoxicated?
Well,
these were cases that were excluded from the study intervention. How is mutual violence determined?
Well, it depends on jurisdiction. I do know that the DVSIR, Kirk Williams instrument, has been used in cases where there's been female perpetrators and/or both, and/or dual arrest, because there's a lot of that in Connecticut, and their data's pretty good.
Okay. Marci, how are police trained in lethality assessment? Is it a long course? How long does it take? Does an outside expert come in, or is it done by people within the department? Or
no. We've done it in a variety of ways. The first step really was to bring command staff in and make sure that they understood the importance of the tool and were on board with implementing it. And then we brought together maybe 3 hours the domestic violence coordinators, all the service providers, and folks who would be involved with the lethality response line. And this was kind of a meet and greet, team building, as well as an information session. And then on each of the in each of the precincts on the shift changes, there was conducted maybe a 20-minute training to make sure that we engaged everybody. And I can share with you, in terms of lessons learned, it's very important when you're conducting the training to have a single training approach, and preferably a single trainer, to ensure that all the same information is disseminated to all the precincts. And it's important. One of the things that we found to be a very effective approach is ensuring, when we conducted the training, is we had someone from one of the domestic violence, actually the supervisor, she's not the supervisor. In theory, you would think she is, but somebody who's a police officer as well as a service provider, so that you kind of cross those boundaries that sometimes are set up between professions.
Is this they look fairly simple, the questions. Is this proven difficult to train police how to administer?
It's not the administering of the tool that I think is difficult. It's getting everybody on board with the importance of this tool, ensuring that there's consistency in administering it. And by consistency, I mean not just asking the questions, but that there's a commitment to really try and reach the victim and ensure that you connect the victim with the lethality response line. So I think the focus is on certainly the skill building component, but that we're more focused on the communication piece. And remember, every jurisdiction is a different size. In Baltimore County, we have almost 2,000 police officers. So it was a large undertaking, and I have to commend both the police and our staff in going to the different shifts. We're talking in the morning, early morning, late in the evening, and in the mid-afternoon to ensure that every police officer, we touch them in some way with this information. And then we do follow-up. I mean, these folks have to provide information. That we collect data on a weekly and a monthly basis. They have to submit documentation data of how many lethality assessment screens they've conducted and what the results were. And when the information, much of the information we're collecting looks accurate and it's right on target, but when it does not, we have both the police manager or overseer of the program as well as one of our someone on my staff go out and sit down with the domestic violence police coordinator as well as the person providing the information to figure out if there's some question what happened, so that we can ensure, I mean, that's a twofold goal. One is to ensure that we have accurate data, but more important to ensure that if the police officer has any questions or there's any confusion, we have a hands-on approach to addressing it in the moment, or as close to in the moment as possible. So at this point, our program is implemented countywide as of May, and each month we're going back. We're almost at the point where we think everyone's really well trained and needs to be where they need to be, but it took us a few months of training and retraining. That was a long-winded answer, sorry.
That's good. We have been told by numerous people now that CDOT stands for Convention on the Elimination of Violence Against Women in International Treaty.
It is the.
So that's right, Rene.
IVAWA International. Yeah.
If enacted, will that provide any additional funding?
Go ahead, Jackie. I'm not as familiar with IVAWA, so maybe you know a little bit more about that one.
It will primarily provide funding for things like trafficking and things that go through the State Department, and it will provide funding for some of the international work, more so than domestic funding, is my understanding. I haven't seen the final language, but.
Okay. Somebody wants to know, do the questions differ can you do a lethality assessment based on what the perpetrator tells you? And if so, is there questions or is there a scale developed for that, where your information is limited to what you're told from the perpetrator?
The ones like the DVSIR get all their information from the police report. So it's, oftentimes that reflects what the perpetrator has said. But that PAS, Donald Dutton's instrument, is the only one that I know of that actually gets information from the perpetrator. Now, the SARA, Randy Kropp's instrument that's used quite widely, again, in probation departments, does get information about the perpetrator, and that information can be obtained from the perpetrator or from the police files.
Okay.
So a lot of that information eventually was obtained, at some point was obtained from the perpetrator.
Here's a question on the police response. Is there any data available on how time-consuming this is for the officer. What is the average time spent by the officer on a high-danger assessment call? Marci, I guess in Baltimore, is it making a difference in terms of the amount of time, or is the officer response the same?
It takes approximately maybe 10 to 15 minutes to both administer this tool as well as connect the person with the fatality response line. And that is balanced, that length of time or that increase in time spent on a scene is balanced by the fact that we saw a large reduction in the number of repeat phone calls. So I think the tool is, as Jackie described it, very easy to maneuver through. There's 3 key questions. Let me just very quickly tell you what they are. Have you been threatened with a weapon? Has the perpetrator threatened to kill you? Or do you think the person may try to kill you? And if there's a positive response to that, the officer immediately knows to connect the person with the fatality response line. And then there's 8 more questions that if there's a response, the phone call is still made. So I guess what I'm saying to you is that it's an 11-question tool. It does add a bit of time, but the value in it is that the police officer leaves there knowing that he's accomplished something by connecting the person with a service provider, and in the future it's believed to reduce the repeat phone calls because the person will link at some point.
Do we know, in those cases, the 56% that were determined to be high danger, how many cases did the police even have to go beyond the first 3 questions to reach that conclusion?
I don't have an answer to that because our police officers, we really have them go through the whole questionnaire. That's our protocol, that even if there's a positive response to the first 3, they still go ahead and ask the other 8 questions.
Jackie, what about nationally, Rene? Do we know how many people answer no to the first 3 questions but turn out to be high danger based on the answer to the last 8?
I have no idea.
I don't know.
I think they have that. They went into that much detail with the pilot. So Dave Sargent would probably have that from the pilot, but I don't think they keep that data on an ongoing basis.
Here's a question. When someone calls the hotline, assuming the victim would like to speak to an advocate, the victim does not have the danger assessment and calendar in front of them. Is it as thorough to complete the assessment over the phone with the victim?
When I do it with the victim, and I do it quite a bit over the phone and online, what I'll do is I'll ask her to find a calendar to look at, to go backwards on, and she usually's got one somewhere around the house, or I can fax one to her or something, or email one to her. And not everybody has access to a computer, but a lot of people do, and we usually manage for her to have do the calendar. But I do think that it's really important for her to do the calendar and then actually look at a calendar. If worse comes to worse, you can kind of draw one out, and I can help her do that on the phone. But we usually manage to find a calendar somewhere.
What about pets? Animal abuse, killing a pet, that's not part of the form. Has that proven not to be?
Yeah, we actually looked at that specifically in the femicide study, and what we found was that pet abuse was definitely a risk factor for domestic violence, and so one could assume that it would be a risk factor for reassault. And it was a strong one. It increased the risk by adjusted odds ratio of 7.5, so 7.5 times. But that was, pet abuse being a risk factor for domestic violence happening at all, and probably for reassault. It did not seem to, in our data, it did not increase the risk for a homicide over and above prior domestic violence. But there were a few cases where he actually killed a pet, and I think killing a pet probably is a risk factor for homicide, but we didn't have enough to be able to see that.
Okay. And not everybody
I
has
don't know
pets.
what all of
so
that
have
was.
that.
Yeah.
Okay. I've heard some father rights groups that have used some of Dr. Campbell's work to say that women are as violent and dangerous as men. Could you please respond to this and to the context of violence by men versus violence by women?
Well, I don't see how they have. I don't. I've heard that too. I just don't understand, because our femicide study was all women killed by men. So it's not clear to me quite how they were able to do that. So I would like to see, just what they use of my work to make the point that women are as violent as men. And I know that there's some other people's work using the conflict tactics scale, that it does look like that. But in terms of being killed, I mean, you saw that, Andy, your slide at the beginning, that now we have somewhere around 4 to 5 times as many women are killed by an intimate partner as are men. So in the homicide realm, there's just, there's no, and, we usually count dead bodies better than we count kicks anyway, so.
In lethality assessment, is this apply as well to female offenders as male offenders?
The data on which it was based on male offenders against females, and so we don't have as good a prediction of it being predictive of the other way around. What research we do have suggests that because, there's been prior domestic violence against the female in so many of those cases, that many of the dynamics are the same. As I mentioned, I do know that DVSIR as a risk of reassault instrument has been used and has been tested with female offenders and is as predictive in risk of reassault.
Okay, but not lethality.
No.
Okay, Rene, can you speak of the importance of domestic violence fatality review teams? In our community, there is a fatality review for homicides, but not a separate one for DV cases.
Yeah, I think that's really important. Again, it's bringing in that whole community to take a look at what's happening in our community and how can we both define the problem and then address the problem collaboratively. So I would say both of those things are really important.
And I would add on, I think that's very important in terms of looking at what our systems do to keep women safe, where, our systems are less good at, identifying the women at high risk. And I know, like, for instance, the lethality assessment project in Ontario, Canada, keeps track of the risk factors from the danger assessment that are present in domestic violence fatalities. So
I don't know if you're aware of all the state reviews and county reviews and fatality reviews, but have the risk that they found in their states pretty much confirm what you found, or are there unique characteristics that certain states have found for lethality factors that aren't present that you found nationally?
Well, one of the things that a lot of the lethality assessment or the fatality review committees do is they only go by official records. So oftentimes I think they underestimate the amount of prior domestic violence there is because they only go by arrest records. And one of the things the Fatality Review Committee in Baltimore does is we actually interview family members, and that's a much more accurate indication of how much prior domestic violence there has been and what's been the nature of that prior domestic violence.
To add on to what Rene is saying, Baltimore County is new to the fatality review process of domestic homicides, but a full investigation. We look at the arrest records, we look at hospitalizations, we absolutely either interview with a professional going to the family, or we've asked the family to come and friends to come to the team meetings. So we're looking beyond what the police records indicate. We're going to a variety of systems, and we found that we've expanded our membership to include our Department of Aging, our mental health providers, so that it's become a more inclusive review process to ensure that we do cover every area, and we're looking to expand it because the group that's often not included is your faith-based communities. So we're in the process, as well as having victims, domestic violence victims, also participate on the team. So I agree, it's a whole community involvement that's important to the strength and the depth of the review.
We are running out of time now. We have just 2 minutes late. I want to thank Jacquelyn Campbell, Marci Van De Mark, Rene Renick for participating. Jim from Center for Innovation, do you have any last words or instructions about people obtaining information if they want to obtain it?
Nothing new, but I'll just reiterate that we will be posting the recording of this event on the Government Innovators Network website in 2 to 3 business days, and you will all receive an email notification when that goes up, and we'll be posting any slides that, pending permission from each presenter, we'll be posting slides along with that recording as well.
All right, well, thank you, everybody, for participating, and good night.
Good night.
Good night. Good night.
So do we sign off now?
Yeah, I think that's it. Everybody can take off.
Okay.
Thank you very much.
All right, Tim.
Have a
Take
good
it away you wanted.